Hello, my name is Dr. Rebecca Resnik. I am a licensed psychologist. You can tell from my accent I'm from the States. Thank you so much for having me as part of this conference, and thank you for spending your time attending this talk. The title of this talk is Diagnosis, the Not Good Enough State of the Art. Now you may say to yourself, Rebecca, you're a psychologist. Why are you hating on your own diagnostic system? Well, I'll tell you why. Because what I do for a living is neuropsychological testing. It is my life's work. And so I eat, sleep, and breathe diagnosis. That's the major thing that I do to care for my patients. It's absolutely critical for me and for all the other people out there, like psychologists, psychiatrists, counselors, that we have a diagnostic system that is based on evidence and that helps people. Psychology and psychiatry and mental health are largely organized around descriptive theory. I can't look at a brain and tell you what's wrong with that brain. Neither can anyone else. I can't put you under a scanner and tell whether you are perhaps at risk of dying by suicide or depressed. What we have, again, is descriptive theory. That means that our diagnostic nosology is based on symptom count, behaviors that we can observe in our patients. As much as I would like to, I can't tell you if you have an abnormal brain, and if you have an abnormal brain, I can't tell you what is going wrong. Because we can't, we are at a loss many times for figuring out how we're going to bring relief and mitigate suffering for our patients. One of the problems with our diagnostic categories is that a lot of the very severe problems occur at low frequency. You may have heard the old adage in science that it is very hard to find a black cat in a dark room, especially if there is no cat. So when we go to study things like how many people are at risk for dying by suicide, you're talking about less than 1 out of every 100 people. So those of you who are researchers, you know that getting to a point where you have enough statistical power to figure out something useful about your population, you have to get a huge N, and you have to be sure that you are going to find some signal in the noise, and if you find that signal, that it's strong enough so that you can actually learn something from it. Differential diagnosis is a huge problem in my field. Now, as Gerd Gigerenzer of the Max Planck Institute noted so brilliantly, in many situations, optimization is impossible. We have so many different examples of human behavior, types of psychopathology. We have a fat statistical manual full of information about psychiatric diagnoses. It's called the DSM, the Diagnostic and Statistical Manual, now in its 5th edition. There's so much noise in human behavior. Humans are capable of being creative and generative. There are many examples of what constitutes normal human behavior, and it's often a judgment call as to what constitutes abnormal human behavior. So the more noise we have, the bigger the search space. This is hard for clinicians. And so what clinicians do as we come up through our training is we rely on heuristics. Those of you who are physicians, you know that you spent a lot of time in medical school memorizing little mnemonics. So for the psychiatrists in the group, if you wanted to figure out if a patient was experiencing mania, you would have a little acronym DIGFAST, dig fast. For bipolar disorder, bipolar family, these help people remember symptom counts, discrete, observable samples of behavior that you can match onto that pattern recognition task of what's going on with this patient when they come into your office. Here's the problem. Big search space, lots of noise, human bias. A meta-analysis by Degani et al. Showed that it can take 6 years from the onset of symptoms of bipolar disorder to get an accurate diagnosis. Now think about that. That's 6 years from the first point of patient contact with a physician or mental health care provider. 6 years for a person who's experiencing mania and depression is absolutely detrimental to their life, and it's very bad for their brain. 6 years of suffering, not only for that patient, but for their family too. Not good enough. A diagnosis is more like an essentially contested concept than it is about a scientifically, empirically provable thing. I can diagnose high cholesterol. I can diagnose diabetes. We can diagnose things in the medical world because we have animal models that help us understand things like how a heart works, how kidneys work. We don't have that for the human brain. In the words of Christoph Koch, when it comes to the human brain, we can look, but we can't touch. So we're relying on behavior. And of course, the problem is when we're relying on behavior, that is defined by human beings. And when I say it's an essentially contested concept, we fight about it. We all fight about what it means to be depressed, anxious, bipolar, schizophrenic. And this is a noisy, noisy search space. I love this quote from Dr. Oliver Freudenreich. He gave us such a beautiful example of how limited our diagnostic categories actually are. Remember, a diagnosis is a tool that conveys information to a fellow professional so that he or she can treat the patient. It also helps us understand what is this person's likely course of the illness. Will it resolve? Will it worsen? So, diagnosis of schizophrenia is a fantastic example because if I say someone is schizophrenic, that could mean almost anything. If we think about all of the possible things that I could attend to in diagnosing a patient with schizophrenia. We also have a huge problem in our field because we are not good at predicting. If I diagnose you with schizophrenia, I would really like to know what treatments are you likely to benefit from? What is your course likely to be? What are the odds that your symptoms will resolve to the point where you can continue to function? Yarkoni et al. 2016 described in their wonderful paper the problem of overfitting. Let's say we grab 50 people and they all have bipolar disorder. Here's the problem. Bipolar disorder is not one unified thing. It is an essentially contested concept. We never have a patient, almost never in the clinical world, have a patient who has just one problem. So all of our studies where we look for this perfect person who has only ADHD, only obsessive compulsive disorder, only schizophrenia, that doesn't exist in the clinical world. And so we're trying to take data from studies where they've artificially controlled the population of an already very noisy search sample, and we can't make predictions from it because what we learn from those studies cannot be transferred out into the clinical world. Let's talk about suicide. Death by suicide is one of the major leading causes of death. It's increasing. This is my friend Mike. Mike was my very dear friend for a long time. Mike died by suicide 24 hours after seeing a psychologist. This is not good enough. Franklin et al. In 2017 looked at the state of the art for predicting who will die by suicide. They found that in 50 years, clinicians have not gotten any better at this. We're good at figuring out population-based rates of suicide death. We can tell you what the rates of suicide are likely to be for a given population, but bring your son or daughter into my office and you might as well flip a coin as to whether or not I'm going to be able to tell you accurately whether your son or daughter is in danger. Again, this is not good enough. We have nosologies that we could look to help us with diagnosis. Contested concepts populate nosologies. Here are three major nosologies. One is the DSM, which I think most of you will be familiar with. They get together and they figure out for each diagnostic category, are there a particular set of symptoms that can be used to distinguish that diagnostic category from all the others in such a way that a clinician can pick up the DSM and diagnose accurately. Now, DSM is not the only game in town. There's also the high-top diagnostic system. This is the hierarchical taxonomy of psychopathology. Kotov et al., the research group up at Stony Brook, is doing remarkable research into a hierarchical-based diagnostic system. We also have RDOC, or otherwise known as RDoC, and this comes out of the National Institute of Mental Health here in the States. It stands for the Research Domain Criteria, and Dr. Tom Insel, former director of NIMH, was the one who really tried to encourage our field to stop looking at descriptive theory, to stop relying on symptom counts, and to start trying to understand psychopathology in terms of the mind and the body and the research and the signal in the noise that we can actually measure. Problems with category-based nosologies? There are a lot. You can read this list for yourself, but let me draw your attention to the very first one, too much or too little symptom overlap. If you remember from your stats class, reliability is necessary for validity. It is not good enough that someone can come into my office and I may diagnose them with OCD. They can go to my colleague down the hall. My colleague may say, no, the primary problem here is substance disorder. They may go to another colleague down the hall, and that person may diagnose hypomania, all using descriptive theory, all using a symptom count-based nosology. And this is the problem that leads us to outcomes like 6 years from the onset of symptoms, or less than chance at being able to predict who's going to die by suicide. Again, not good enough. Dr. Tom Insel very famously broke up with the Diagnostic and Statistical Manual of the American Psychological Association back in 2013. Dr. Insel argued that symptom-based diagnosis has been eliminated virtually from all of medicine, and yet we in mental health still rely on it. And what I want you to take away from this is what he said: patients with mental disorders deserve better. Well, let's talk about how we can get better. Should we be looking at biology, behavior, or cognition? We have models of each, but in the words of the great George Box, all models are wrong, but some are useful. We need useful, the ones that give us predictive power. Here's another problem. Human reason is biased and lazy. The great Mercier and Sperber wrote in their book, Human Reason, when a human being comes in contact with another human being, there's a whole bunch of blind spots and prejudices, and sometimes we're just plain old tired and we miss that signal in the noise. So how do we get better at this? One of the ways we can get better at diagnosis is to stop thinking in terms of trying to figure out system counts and start thinking about the two core issues of diagnosis, and that is functional impairment and subjective distress. Things like Kotov et al.'s project out at Stony Brook help guide us in our thinking, not so much around what diagnostic category can we fit this into based on the symptom count, but how do we really understand what's going wrong with this patient so that we can suggest a treatment. Here is RDoC trying to integrate the biology, the cognition, again, looking for signal in the noise that is not just based on theory, but based on things that we can measure. Now, if you look down at the bottom where it says units of analysis, behavior is one piece of that. Here's what I would like to propose. I'm a Monty Python fan, of course, so here's my tribute to Monty Python. Let's quest for the grail. The holy grail in the world of mental health is that we need diagnoses that are cheap, reliable, valid, and can be deployed along a great stretch of the population. We don't have that now. If you're lucky enough to get in front of me, it means that you have enough money to pay to come and see me, a private psychologist. We have large swaths of territory in the United States, 2 of them in the middle of the country, and they're known as the suicide belt and the mental health deserts. We need ways of reaching these people because, again, we're missing a lot of them. We're missing a lot of their suffering, and people are dying needlessly of overdose and suicide. So here's a modest proposal. If you're like me and you are a biological mother, you have given a lot of urine samples. Let's think about a urine sample. This is an incredibly elegant way of collecting data about multiple organ systems and functionality. When you go into a physician, they can learn a myriad of things about you based on a non-intrusive procedure of collecting a sample. Let's imagine that instead of taking the physiological sample, we were able to get a sample from the mind, and that sample can be language, that sample can be behavior, that sample can be the quality of my voice, that sample could be microfacial expressions. But let's look at just language technology. What if every time you went to the doctor, not only did you leave a urine sample, a blood sample, but you left a language sample? Imagine you left a language sample with an avatar or with a tech or with a nurse, and that physician was able to use a computational algorithm to come into the office already prepared with a document indicating what you are at risk for. Imagine your physician could come in and know that you were at risk for depression, suicide, substance abuse, anxiety, and point you towards a mental health professional where then you could be connected up with means of alleviating your suffering. Thank you again for attending.